Thank you very much. I have sort of two microphones now, and I don't know which one works, so I might act a little weird, but just trying to make myself understood. Thank you very much for this introduction, and thank you very much for inviting me, Professor Knecht, Professor Stöttner. It's a pleasure to talk to you here about toxicity of targeted therapy. Now, when we talk about quality of life, as has been pointed out in this very elegant introduction, it's very difficult to discuss that in this context. Rather, it's much easier to discuss this in the context of toxicities that we induce, because one would consider, once we are using targeted therapies, which means that we're targeting certain transduction mechanisms or receptors on cell surfaces, we would expect that we're doing something extremely specific. Obviously, a lot of other mechanisms intermingle with what we're doing and interfere with the specificity of action that we're expecting to achieve. Now, one of the major steps forward during the last decades was the introduction of anti-EGFR therapy into the treatment of patients with head and neck cancer. Now, apart from other indications, including chemotherapy, refractory tumors, mainly colorectal cancer, frontline therapy in colorectal cancer combined with chemotherapy, neoadjuvant therapy in unresectable liver metastases, now the introduction of adjuvant therapy in colorectal cancer and non-small cell lung cancer, and the maintenance therapy after chemotherapy induction, we do have now a testing for radiosensitizing activity in rectal and pancreatic cancers, and finally the radiosensitizing activity of anti-EGFR therapy in patients with head and neck cancer, as well as first and second line treatment in this disease. Now, this was a very broad attack on very various tumors, and I would want to concentrate, of course, corresponding with today's event, on the last 2 points. However, I want to deduct from the previous points on toxicities, side effects, and arrive at a certain conclusion which might lead to head and neck cancer. Now, the response to treatment in the BOND trial was designed in order to test for the efficacy of Erbitux, which is cetuximab, after irinotecan resistance. And interestingly enough, the addition of cetuximab to irinotecan induced a partial response in 23% of patients who were shown to be resistant to irinotecan, with a median time to progression of 4.1 months, which was very impressive and which made a breakthrough in the arena of treating patients with colorectal cancer with this drug. Now, you see this very nicely here. Graphically, time to progression was significantly prolonged by the combination of irinotecan with cetuximab, as was overall survival, which was very similar in this context. Now, the interesting story was that in contrast to other targeted therapies, the percentage of cells which expressed or overexpressed epidermal growth factor receptor did not correspond with the treatment response, nor the staining intensity did. So there is something which we might not understand in this context. However, what occurred in almost all patients who responded was skin toxicity, with an 80% incidence, which was an acne-like rash or xerosis, paronychia, or lashes. This did respond well to antibiotics, either topical or systemic, resolved with interruption, and, as I said before, correlated very well with treatment response. I will come back to that a little later. Now, when you look at grade 3 and 4 toxicities and look at other side effects, this acneiform rash occurred in 9.4% of patients on the BOND study, and this was only exceeded by diarrhea, asthenia, and neutropenia, which were all chemotherapy related and not that well explainable by the addition of cetuximab. In other combinations where you used cetuximab plus FOLFOX, which is a combination of fluorouracil, leucovorin, and oxaliplatin in patients with metastatic colorectal cancer, again you found this acne-like rash in 21% of patients, signifying that this side effect was not specific for the combination of cetuximab plus irinotecan, but rather occurred regularly in the combination of this antibody with any kind of chemotherapy as well. I will show you a little later. Now, when you used a combination of IFL, which is again irinotecan, fluorouracil, leucovorin plus cetuximab, you again arrived at this 21% mark of acne-like rash occurring in patients. So this seems to be rather the rule in patients who are being treated with this compound. Now, let's take another look at another disease entity, which is non-small cell lung cancer. And again, there was this study performed with cetuximab plus chemotherapy versus chemotherapy alone, which showed an overall survival at 24 months by the use of chemotherapy plus cetuximab in 40% of patients versus nil with chemotherapy alone. And you find this here, the survival curves presented graphically. Now, again, what you find here is this acne-like rash occurred here again, but in a lower percentage of patients. Only 5% of patients developed this acne-like rash in this context. So you might want to consider that this might be rather disease-associated than therapy-associated. However, when you went back and looked at a subset analysis of skin toxicities, you find that the combination of cetuximab plus chemotherapy was very much related in this study as well, and in non-small cell lung cancer as well, with skin toxicity. You find that patients with skin toxicities of grade 1 had a lower likelihood of response, complete and partial remissions of 24% versus grade 2 in 31%, and grade 3 skin toxicity, although the number of patients was small, was associated with a 100% rate of complete or partial remissions. So again, there is something which is correlated concerning skin toxicity with the efficacy of treatment. And really, when you look at the presence and intensity of rash predicting increased survival, you find that with increased toxicity grade, with violet no reaction and yellow grade 3 toxicity, you find that in almost all diseases and entities that were studied, you find a very close correlation between survival and the occurrence of skin toxicity, including colorectal cancer, including pancreatic cancer, including head and neck cancer. So again, you have this very close relation, which we really cannot define and understand appropriately. Now, when we come to the subgroup analysis and correlate skin reaction and efficacy, we find that this is not only true for the number of patients with grade 3, but also for the duration of time to progression and median survival. So this is a very good parameter. Although this is limiting quality of life and is sometimes very unpleasant for the patient, this is something which we really rather look forward to than we do not want to occur in the patient. Now, the challenges here are, of course, quite interesting. That is the prediction of response and the selection of patients. So we have something which is limiting quality of life, but according to which parameter we could rather select patients for further treatment. Efficacy and overexpression of the target are not an issue, obviously, and predictive markers are quite interesting because this is quite well connected with MEP kinase activity with AKT or STAT3 and EGFR gene mutations, leading to an altered sensitivity to tyrosine kinase inhibition. However, might not be very well related to the use of the antibody, and here we need definitely more translational research. So the skin rash test, which we might call this, is something where we could discuss whether dose escalation should be done using cetuximab until we see response and the patient does develop the skin rash that we were discussing before. Now, these treatment considerations have been translated into the Everest study, which is a dose escalation study in patients with colorectal cancer with serial skin and tumor biopsies, looking to achieve this acne-like rash in order to respond and in order to see whether this kind of response can be achieved by an escalation of the dose of cetuximab. The design is quite easy. We have the group A, which is this classic design here, irinotecan plus Erbitux, 250 milligram per meter squared, and the group B with a dose escalation every second week until skin toxicity of more than grade 2 occurs, and the group C, which is again a classic arm. So only when skin toxicity occurs, patients are included into this group C. Now, the primary endpoint is the difference in expression of epidermal growth factor receptor and other downstream signaling pathway markers in skin biopsies in order to understand what happens within the cell. Now, this is quite difficult to obtain, as you see that there's a lot of downstream markers and downstream genetic mechanisms happening after the activation and the interaction of epidermal growth factor receptor with its antibody, which is cetuximab here. And you see that this inhibition here, of course, limits a lot of mechanisms, mainly the AKT genetic pathway is knocked out, sort of. So what we can look at, of course, is a lot of mechanisms, including EGFR, MAP kinase, P27, and AKT as well. So there's something with a lot of translational research which has to be done in order to understand what we actually are doing here. Now, in head and neck cancer, there is experience with cetuximab in the first-line treatment of recurrent or metastatic disease, experience with cetuximab in the treatment of recurrent or metastatic disease refractory to platinum-based chemotherapy. And there's results of an international phase 3 study of radiation plus minus cetuximab in patients with locoregionally advanced head and neck cancer. And I very shortly want to go with you through this and discuss with you cetuximab plus cisplatin or cisplatin with placebo in the first-line treatment of advanced head and neck cancer. And again, the safety issues, rash occurred in this study in 18% of cases. And let me draw your attention to the fact that hypomagnesemia was another problem occurring in 14% of patients. We know from a very recent publication in the Journal of the National Cancer Institute that hypomagnesemia is an issue in the treatment of patients with cetuximab and should be looked at and should be taken into account when you're treating patients with this compound. Now, combination with cisplatin fluorouracil or carboplatin fluorouracil in combination with cetuximab and safety issues are, of course, rather platinum-related than cetuximab-related and do not play a major role in our considerations. Now, let us go very shortly through the results of this phase 3 study, which was discussed today already, radiation plus minus cetuximab in patients with locoregionally advanced head and neck cancer, which was published very recently. Next slide, please. Doesn't work. The survival is influenced by the addition of cetuximab. You see this graphically as compared to radiotherapy alone. The same thing is with locoregional control. The addition of cetuximab significantly influences locoregional control over radiotherapy alone. But the most common side effects, again, are skin reaction of rather severe grades 3 or 4 in the combination of radiation plus cetuximab, occurring in a rather high number of patients, including mucositis and stomatitis occurring in even more patients. So that is something which is unpleasant and what one has to watch when doing this treatment. However, the outcome is mainly without sequelae, and mucositis, as well as increased tiredness, fissures of the skin, and dry skin is of a rather limited duration, except for dry skin, which might be ongoing. However, all other side effects are probably of limited duration, and the outcome is either without sequelae or the side effects resolve after the termination of treatment. So this is my final slide here. When we come to side effect profiles of targeted therapies, this is quite interesting to see that cetuximab does induce a couple of